Dear colleagues here in the studio, as well as those who are watching us online, warm welcome. My name is Jan Blatný. I'm a hematologist at Brno University Center in Czech Republic, currently serving as a vice president of EHAD. And together with two distinguished colleagues, Professor Niamh O'Connell from Dublin, Ireland, who serves as a national director for haemophilia in her country, as well as Professor Paul André Holme from University Hospital in Oslo, Norway. We'll be discussing today the possibilities of further changing, further elevating, and further improving the care for people with haemophilia. This discussion perhaps may sound to some of you very ambitious or visionary or aspirational, but we believe that it's fine because this has happened many times in the past. We all may remember that 50 or 60 years ago, nobody would believe that the prophylaxis would become a true, and it happened. During the HIV crisis, we even did not believe about the possibility of having entirely safe products, and we have them. When we started primary prophylaxis with recombinant concentrates some years ago, it was another change. And currently, with the gene therapy knocking on our door and non-factor treatment and other improvements, we believe that right now it is a time to change the paradigm. Right now it is the change to, it's the time to think about the changing how to view on haemophilia, on its further care, and how to further elevate the treatment. When we are thinking about the change of the paradigm, about the change of our approach, about elevating the level of the treatment, we indeed have to think if we have enough power, if we have enough in our hands to do so. And I believe that we do, because currently a lot of changes has happened in the treatment landscape. And a lot of us remember, let's say 10 or 15 years ago, when we started to discuss the principle of the zero bleed as a target for the treatment of haemophilia. Some of us were skeptical, saying it's not possible to have zero bleed for those who are having haemophilia, but it is true now. In many countries, including mine, and I'm sure including yours as well, the median bleeding rate, annual bleeding rate, is zero or very close to zero. So we are there, we are already there. And it brings up the question if we shall be happy with what we have, or if we should aim for more. And I believe that we not only shall, we have to, because it's something we owe to our patients. It's always it's a must to do something more for the patient if you can. And we believe that we really can. So what would be the further step, further goal, further aim in elevating the care? So my first question for you would be, how do you see, if at all, the difference between normalizing the life, which we almost achieved, or achieved in many countries, and the aspirational goal, normalizing the haemostasis?
Thanks, Jan. I think this is such an important question for our community at the moment. We've seen such fantastic improvements in prophylaxis over the last 10 to 20 years, so that we've been able to extend prophylaxis from children and young adults right through our community of patients. And for definite, they have benefited from having lower bleed rates. But now I think we can even look further than that, because our patients are telling us that they want to have the same opportunities and choices as their peers without haemophilia. And they want to do so without having the burden of haemophilia treatment. We understand, of course, that they'll have to take treatment, but it is not going to be feasible for them to take it so frequently that the treatment becomes the main focus of their lives. We want them to be able to focus on the other objectives that they have in their lives, in their professional careers, in their family life, and in their sporting activities. I believe now that we have a spectrum of treatment options for patients that allow them to make those choices more easily than they have done in the past. And I think that it is a testament to the improvements in care that we can now even talk about normalising haemostasis. and taking our treatment for patients to a new level.
Oh, yeah, I totally agree. I think that, but on the same time, I think it's a difference between normalized hemostasis and a normalise. I think that many of our, at least young patients that started out with primary prophylaxis very early, they have very pristine joints. They have very personalized treatment, although they don't have normal hemostatic levels. I mean, they are able to live a pretty normal life with a very personalized treatment. However, I think we should still extend to the normal hemostasis, which we have the possibility today with the new treatment options. That will make the actually life easier for these people. They don't have to do the same, that will probably improve the adherence as well for treatment, and we can avoid those bleeds that might impair the joint function. So we can eliminate that chances of having joint failures in the future for these guys.
Question which of course comes always sooner or later is, are we or can we afford this? And I believe that with the new treatment options and with the new ways we are approaching the treatment of hemophilia with, it is possible. To me, it doesn't mean that elevating the level of the care necessarily means to increase significantly the costs. And as you've already mentioned, both of you, together with that, it also lowers the burden of the patient. So my feeling, my understanding is that with the current armamentarium we are having or are going to have in our hands for the treatment of hemophilia, we can afford it because the treatment will be higher for a comparable costs, and it definitely will lower the burden for the patients, and thus probably also increasing their willingness and their adherence. So do you see it similarly, or do you have different option of view?
I agree to that. I mean, from also another perspective, I mean, the healthcare providers, I mean, if the patients are more well treated, they don't need the same follow-up, and we don't have to focus on their bleeding problems, but we can focus more on comorbidities and things that we know that as life expectancy are increasing, we can use more resources on that, and from a cost perspective, that will actually gain the whole population. So of course it's difficult to talk about costs, and that's very different from country to country, etc., etc. But I think that this is the way forward, definitely.
I think we also need to think about haemophilia as a lifelong condition, and if we have children and young adults who come out of their primary prophylaxis phase with very healthy joints, we've got to try and preserve those for the rest of that person's lifetime. And I think the burden of treatment is a kind of key factor in that, because if you have a treatment that's very burdensome, unfortunately, many young and older adults find it very difficult to comply with it, and they lose the protection that they'll have had earlier in their lives with the consequent damage that will occur to their joints. Added to that, then, you have the usual aging complications of normal joints. And I think that you end up maybe with people with considerable joint disease, even though they've had access to good treatment. So I think we've got to be trying to optimize people's protection right throughout their lives. And the more we can reduce the treatment burden and improve the hemostatic cover they have, the more likely it is they'll reach older age with healthy joints and no complications of bleeding.
So based on what we've discussed, I think we can say that the first take-home message is that normalizing hemostasis is not the same as normalizing life, and normalizing hemostasis is achievable and affordable goal we shall go for on our way of further elevating the care for people with hemophilia.
Hi, I'm Paul André Holme, Professor of Hematology at Oslo University Hospital, and also the head of the Haemophilia Comprehensive Care Center in Norway. Today we have, in the first session, we have discussed whether normal hemostasis is the same as normal life. Now we will aim to look into more how we can elevate our standard of care for our hemophilia patients to get there. Until quite recently, at least, we have been measuring ABRs, factor consumption, and the last years aimed for zero bleeds. However, we still know that persons reporting zero bleeds, they do have joint damages. We learned that from the Johnson paper in 2007, where we saw that those many patients that didn't report any bleeds, they still had a high MRI score. So how can we elevate our standard in the future? I mean, we have got some new tools that we can make use of now. I mean, we have not only longer the standard half-life products, we also have the extended half-life products and also the super extended half-life products, in addition to gene therapy and non-factor replacement therapy. So how can we really elevate our standard? I mean, still we have joint problems. Will we get rid of those things if we just get into a factor level of 40%, for instance? And how should we monitor this? Should we do something in our practice to change our practice to monitor these patients better?
I think it's a challenge for us in the haemophilia community because we don't have an optimal outcome measure.
No.
You know, we've been monitoring, as you've mentioned, our bleed rates, our joint health scores, and sometimes we've been able to do imaging such as point of care ultrasound and MRI. I don't believe we've finalized a perfect outcome score. I think at the moment we have to put together all of the different outcome measures and put them together with some better quality of life measures also, which I think have been somewhat problematic for us as well. At present, I don't think there's one particular outcome measure that is better than any other. I think we need to look at the full picture for each person and each patient. I think we need to be talking to our patients about their goals and aspirations also and putting them together with our objective measures of care. For some of the treatments you've mentioned, we will also be able to assess factor levels. And we do know, obviously, that if we can measure a factor level and get it into something approaching a normal factor level, that will give us a bit more reassurance also. But my own view is that I don't think we can say that there is one specific outcome measure. And I believe that it's the longitudinal following of patients who are receiving these treatments, where we have good data repositories of outcome measures over time, that will give us the information that we need, I think, to convince ourselves and our patients that we have done the right thing to increase their standard of care.
Yeah, any thoughts?
What we currently, and not only we, but all the stakeholders in the community, including the World Federation of Haemophilia, EHC, scientific societies, we rely and have relied for many years on the ABR and on the factor 8 or 9 consumption. Regarding the ABR, once we reached or are reaching zero bleeds, I think that we shall keep this because this is something we need. And with the new treatment, this is some sort of new standard of care which has to be capped anyway, because even if we quote Michael Johnson's paper, of course there were some patients who were having zero reported bleeds, but they had the microbleeds. But should they have more bleeds, the devastation of the locomotory apparatus would be worse. So I think that instead of being the holy grail of the hemophilia treatment, it shall be some sort of standard which is in the background and there is no go to go back. So keeping zero bleeds or close to zero bleeds, that is something which we shall keep. Regarding the factor 8 consumption, I don't think that this is a parameter which should be universally used for the future. Not only because we are having the gene therapy, which it will not work for that. The same is for non-factor treatment. And also, if you treat very effectively with extended or super extended half-lives, the amount of the units used will be lower. And it doesn't mean that the level of the care is going down. So that is one thing which the community have to adapt to, that we have to use or change those measures. And I would fully agree with what both of you said, that we shall somehow more incorporate the patient measurement parameters. So something which is mirroring their satisfaction. My view on the medical service is not that the doctor has to or shall or should say to the patient what he or she should do, but to help him or her, him in this case, hemophilia, to guide through the life with minimal complication or ideally no complication. And to be able to do so, I need the feedback from the patient. And I believe that it shall be more incorporated into the way how we judge our success in the treatment.
But what do you think? I mean, today's successful treatment is very much based on personalized treatment. I mean, for pharmacokinetic measurements, etc. Do you think that if we aim for a more normalized hemostasis, like equivalent to 40% of factor 8 or factor 9, do we need that kind of personalized treatment? Are we above the limit so we can relax a little bit more concerning PK measurements, etc.? Do you have any thoughts about that?
Yeah, I think PK measurements certainly got easier when we were able to do limited testing and we were able to use some of the algorithms that allow us to predict PK. So it became easier to do in more recent years. But even so, I think it was probably more relevant where we had standard half-life therapies, more frequent infusions, and we were trying to really optimize the frequency of infusion and the dose we were giving each individual person. I don't believe it's as critical with extended half-life or even super extended half-life factor treatments. And obviously for treatments like non-replacement therapies and gene therapy, it doesn't really impact so much. So I would agree with you. I think that concept of personalization as only meaning PK, I wouldn't agree with. But what I do feel is that personalization has to take into account the views and preferences of the individual person, their particular experience of haemophilia over the course of their lifetime, their particular complications of either haemophilia or any other medical condition they may have, and the stage of life that they're at. And we do know that, like all of us, people's requirements for their treatment will change according to the stage of life that they're at. I think if we can engage our teenagers and young adults in a good conversation from the beginning of the time that they transfer over to the adult services where they're now really making all of the decisions for themselves, that'll set a good benchmark for them for later life in order to be open with their treating team, that they can really discuss all of the different options that are available and really match the treatment to the needs that they have at that moment in time. But with all of the treatments, I think it's true to say that absolutely we need to have excellent protection from bleeds with the least amount of treatment burden we can achieve for the person.
I would echo what you've said. And indeed, the personalization is not only the level of the factor. And it is all those things you've very nicely commented on. One of the ways of personalizing the treatment is also, in my view, currently to choose what is the treatment ideal for that person. Because for somebody, it may be gene therapy. For somebody, it may be extended half-life. For somebody else, it may be non-factor treatment. So this is also the way of the personalization.
We started out talking about outcome measurements. I mean, we have this ABR reporting from the patients. I mean, should we aim for more objective methods to really evaluate the treatment? I mean, should we all do ultrasound, for instance? Should we all do MRI?
It would be ideal to have it.
Or do you have any other suggestions for biomarkers that might help us here?
I'm quite a believer in ultrasound, so I think that this is non-invasive, very easy, and once we are working within the multidisciplinary team, there will always you find somebody who is into and who is doing it well. So in some countries it will be physios, in some countries it will be nurse, in some countries it will be doctor. So I believe that this is for almost no cost, very useful thing. But on the other hand, it will not sort out all the problems. So this is one thing which I believe should be incorporated into our way how we judge the treatment we provide. And on the other hand, it would be ideal to have also help from the psychosocial workers, because once we get off the very visible impact on health, like a bleed or a debilitating arthropathy or whatsoever, then we have to be able to somehow compare and evaluate the level of this normal life, if it is normal enough or if it is not normal, but satisfactory for the patient. And it will be also a lot of personalization, because what is satisfactory for me may not be satisfactory for somebody else.
One point I would make, Jan, about the point-of-care ultrasound, and I do agree with you, it is non-invasive, it's acceptable to patients. I think people like to be able to visualize their joints, and I think that's very good when you're trying to educate patients about their treatment and the importance of adhering to it. The only thing is that with all of our measures, like our joint health score, our point-of-care ultrasound, even our bleed rates, we're detecting damage already when it's occurred. And I suppose what I would like to see us aiming for is a treatment that truly protects people. So our point-of-care ultrasound is only confirming that we are achieving our goal, rather than waiting for damage to happen and then responding to it. I think that's what we've done in the past in a way, like we've allowed people to bleed their way to the right prophylaxis dose, because, you know, we were focused on bleeds. We allowed almost more bleeds in the past than we would consider appropriate now. And I think we've learned that that wasn't the right approach. I think that the damage had occurred at that point. Okay. So really, I think what we want to be trying to do is get fantastically protective treatment and use our point-of-care ultrasound to delineate maybe some of the other joint or orthopedic issues that might arise over the course of somebody's life, and maybe pick up the occasional person, hopefully, who needs a different kind of treatment, perhaps relating to their particular activity. I'd also mention that I think your approach of qualitative research in the area of people's satisfaction with their treatment and their life goals, I think could be very informative here, and I think we need to do more of that.
As for the regarding the ultrasound, it all should be negative. That's the goal. So it was not meant like pick up the problems, but regularly check, also for the educational reasons, as you mentioned.
So that means that if we had normalized hemostasis, we don't need ultrasound or at all, perhaps. I mean, then we wouldn't have any subclinical bleeds or microbleeds, perhaps.
I think that's what we have to aim for. If we're, you know, if we're truly talking about controlling the effects of haemophilia on people's lives, then that's where we should be aiming.
Okay, thank you for my discussion. So I think we have discussed a little bit about how to elevate our standard of care if we're aiming for normalizing the hemostasis. And the real take-home message should be that with the new treatment options we now have available today and will have in the future, I mean, normalizational hemostasis are not only zero bleeds, but so much more.
Hi, I'm Niamh O'Connell. I am the Director of the National Coagulation Centre in Dublin, Ireland. And we've been discussing today a new concept of normalising haemostasis as a new standard of care for haemophilia treatment. I think the question comes, though, when we accept that this is the new paradigm for care for patients. How do we implement this in our daily practice? I'm delighted to be here with two treaters of haemophilia who have enormous experience in looking after people affected by haemophilia. And I'm interested in your views on how we should approach the care of specific patients when we're trying to achieve normalisation of haemostasis. I might start, Jan, with a very typical patient, a young adult who is perhaps going to college in his late teens or early 20s, and naturally wants to engage with his peers and friends in sporting activities. Maybe he's part of a soccer league, he's training a couple of nights a week, he's matches at the weekends, and sometimes has a kick around with his friends as well, impromptu and unplanned. How are you going to discuss normalising haemostasis with a patient in this age group, do you think?
Well, I think that if you asked this question 10 or 15 years ago, I would say that would be the most difficult group of the patients to discuss with, because to get the proper care, it would impose a lot of burden on the patient, because there would be numbers of repeated injections frequently to get the levels high enough to cover for all those activities you've mentioned. Or the patient would have to refrain from many things he would love to do. Currently, I think that the situation is entirely different, because we are having the new ways of treatment, either non-factor treatment, which will not get to a certain level, but will improve the hemostasis to near normal levels, or super extended half-lives, where with reasonable dosing schedule, he can have the good or near normal levels as well. If it is a young adult or teenager, then I would not think about the gene therapy because it's not registered yet, but still have plenty of more options than before. So currently, I would say that this is not that difficult, though it, of course, will need some discussion. I think that another advantage we are having currently, or we are having now compared to the past, is that most of the centers are working in a multidisciplinary way. So there are multidisciplinary teams, so it's not only the nurse and the doctor who is approaching the patient, but there is a possibility to discuss this with the social worker or the psychosocial experts, and also within the peer groups, because that's something which also helps. And there's plenty of educational materials which are available not only from the scientific but also from the patient's organization. My suggestion for that particular patient would be to go either for the super extended half-life, or once it is available because it's very close, or should he be in the United States, then it's already available. And I'm sure that more of these molecules will come, or think about the non-factor treatment. I believe that this is currently the way to go further. And should this be somebody who is over 18, indeed, the gene therapy would be one of the options as well once it's available in a particular country.
And Paul, do you think there's any activity now that we should say is off limits to our patients, or are patients' expectations set in the right level, do you think, in relation to their sporting choices?
Yes, I think, unfortunately, it is. I think that contact sports should be, at least they should avoid. However, it's always a big question concerning soccer, for instance. And if they will succeed without any damages, I mean, you really have to have a high impact personalized treatment. I mean, you really have to tailor these patients to if they are going to be successful. So that's why that kind of patients is very challenging. I mean, to have pristine joints, to have a normal life, I mean, and still have the ability to do whatever he wants to do. And I think that it is achievable with factor replacement therapy. However, it's quite demanding. It is possible with the new super extended half-life products. It is possible with gene therapy if it's a responder. I don't think it's might not be that successful if it's a very active guy on non-factor replacement therapy. I mean, I think we are too low there to do high energy sports, for instance. So yes.
So it's a very detailed discussion with our patients when they're in the clinic, I think, and really trying to understand exactly what level of sport they're participating in and exactly what risk they might be undertaking in their particular sport. And obviously that will vary from country to country depending on what the popular sports are in your local area. Mm. And I'm wondering also about people in the older age spectrum, Paul, because, you know, one of the wonderful achievements of haemophilia care over recent decades has been the increasing life expectancy, but with that has come the usual comorbidities that people can have, and that sometimes does create, I think, some complications for us as haemophilia treaters. So if we were to think about somebody in maybe their 60s, who's developing something like ischemic heart disease or atrial fibrillation, maybe somebody who hasn't had, obviously, primary prophylaxis, perhaps now has access to secondary prophylaxis. How do you approach shared decision-making with a patient in that age group heading into the period of their lives when comorbidities are becoming more of an issue?
Yes, I mean, hemophilia patients should have, even if they have comorbidities, they should have the same treatment as the general population. So that's our challenge, actually, as treaters. And I think that it's very often to combine dual antiplatelet therapy for I mean, that patients have gone through PCI, etc. If they have atrial fibrillation, should they have oral anticoagulants in addition or anticoagulants in addition? And what trough level should you aim for? And that also is challenging. I mean, you might increase the treatment burden with more frequent injections, etc., at least with the treatment that are available today. And this is things that I think will be much more simplified in the future when we can use these more extended half-life products or gene therapy. I mean, then we can focus really on the comorbidities and not on the hemophilia. And so, I mean, they can have anticoagulation if they get atrial fibrillation, if you have a certain level of factor, at least if you aim for 40%. And what we're discussing today is about 20, I guess, for oral anticoagulants. And if we have dual antiplatelet therapy, I think it's a consensus that we can do dual antiplatelet therapy if you have at least a trough level 10%. I mean, so I think from that perspective, I think also our job will be easier if we go for normalization of haemostasis in the future.
Would definitely agree with what Paul said, because for me it is only an asset if we are able to normalize the hemostasis, because those issues which were, or those problems or those comorbidities which were related to hemophilia shall cease, like obesity because of the lower possibility to move and so on. And on the other hand, if the patient is having other comorbidities, then it will be for us much easier and more standard to treat, because then the typical thing is the ischemic heart disease treatment. So you always have to elaborate between the clotting and the bleeding. But if you have the normal or close to normal hemostasis, then you can act standardly. And more standardly you act, the better the results are. That's what we have the standardization for. So for me, there is definitely no reason to think that the ultimate treatment, the normalizing of hemostasis, should be only for those who are young, who are with pristine joints, who haven't had the joint disease happen. But I think there is no age limitation, and in every part of the life, it will find its pros. So for me, there would not be any difference in an approach. It will be an application of it, but not in a principal approach.
And Paul, how important is how we organise care in comprehensive care centres, haemophilia treatment centres, in this new paradigm of normalisation of hemostasis, do you think?
I think that's extremely important, actually. I mean, I think that we need these comprehensive care centres that really know our patients. And we should also have, when you're talking about life expectancy is increasing, we have comorbidities. We should also expand perhaps to other specialities to cooperate more with them, actually, in that concept. But I also think that perhaps if I see a group now that have severe joint disease because they didn't have any primary prophylaxis, and they will, of course, need all the resources they can have to also to cope with their joint problems in addition to their comorbidities. But in the future, I see for those who have started, those patients who are in the 30s, 40s today, they seem to be pretty normal living. And I don't think that they, so I think in those patients, when we change those patients to a more normalized hemostasis, I think that we can drag down concerning psychological resources, etc. Because I think the burden of having those joint problems and they're anxious about their joints and what they can do and not do, I think that will perhaps disappear a little bit in the future, and we can focus more on the comorbidities. They actually
and we do have the advantage of longitudinal follow-up, and I think that's going to be very valuable in terms of monitoring the true outcomes that people have over decades rather than over a smaller number of years.
I also think that even if in the future we may not need that many centers, the institution of the comprehensive center and perhaps the treatment center still shall be there, shall continue, because we need the expertise, and there will be plenty of new things we will be dealing with, like the comorbidities and more invasive procedures and so on. Patients, on the other hand, if if they not bleed, they may lose some of their skills and experiences they had before, because if you have something which is repeating very frequently, you are able to cope with it better. But this means that the centers shall be there for them, because they may not be that certain about the respective situation, and they have to be able to seek for the advice in a very high expertise available center.
Yes, I think for sure we've learned over the years that concentrating the expertise for rare disorders with a small number of expert centres definitely improves outcomes in many different medical disciplines, not least haemophilia. And there's no doubt that we are entering a new era now of multiple very effective treatments. But still, I think we have a lot to learn about how to follow and measure the outcomes with these new treatments. And I look forward to going on that journey with you both and our colleagues across Europe. The take-home messages from our discussion today: normalisation of haemostasis is appropriate and possible at all stages of life for people with haemophilia. I'd like to thank my two colleagues, Paul Anders Holm and Jan Blatny, for joining us today. We've had a very detailed and interesting discussion about normalisation of haemostasis as a new standard of care for haemophilia treatment. We'd like to sum up now the takeaway messages from today's discussion. Normalisation of haemostasis is an appropriate and realistic aim in the treatment of haemophilia, and new medications are a prerequisite for achieving this aim. Normalisation is more than just zero bleeds, and normalisation of haemostasis is achievable and adaptable to all stages of life. We'd like to thank you for joining us at this discussion today. We'd love to encourage you to share this video widely with your colleagues, your multidisciplinary team, and your patient community. And we'd love to see you taking this concept of normalisation of haemostasis into your clinical practice wherever you are. Thank you.